Session. To begin, I would like to invite Najib Ahmed to start with a word of prayer.
أعوذ بالله من الشيطان الرجيم. وقال الذين لا يرجون لقاءنا لولا أنزل علينا الملائكة أو نرى ربنا لقد استكبروا في أنفسهم وعتوا عتوا كبيرا. يوم يرون الملائكة لا بشرى يومئذ للمجرمين ويقولون حجرا محجورا. وقدمنا إلى ما عملوا من عمل فجعلناه هباء منثورا. أصحاب الجنة يومئذ خير مستقرا وأحسن مقيلا. ويوم تشقق السماء بالغمام ونزل الملائكة تنزيلا. الملك يومئذ الحق للرحمن وكان يوما على الكافرين عسيرا. ويوم يعض الظالم على يديه يقول يا ليتني اتخذت مع الرسول سبيلا. يا ويلتى ليتني لم أتخذ فلانا خليلا. لقد أضلني عن الذكر بعد إذ جاءني وكان الشيطان للإنسان خذولا. وقال الرسول إن قوم اتخذوا هذا القرآن مهجورا وكذلك جعلنا لكل نبي عدوا من المجرمين وكفى بربك هاديا ونصيرا. وقال الذين كفروا لولا نزل عليه القرآن جملة واحدة كذلك لنثبت به فؤادك ورتلناه ترتيلا. ولا يأتونك بمثل إلا جئناك بالحق وأحسن تفسيرا. الذين يحشرون على وجوههم إلى جهنم أولئك شر مكانا وأضل سبيلا. صدق الله العظيم.
Shukran Najib for the wonderful recitation. Once again, welcome everyone to tonight's session. This session is brought to you by the academics departments of Msaoun KNH in collaboration with Peace Medicine. My name is Abdullah Hassan, and I have the honor of serving as the Vice Chairman of Msaoun KNH, and I'll be the moderator for tonight. Tonight, we are excited to dive into a fundamental clinical skill, that is, how to read and interpret an ECG. This is a part one of a two-part series. Tonight, we'll be covering an introduction to ECGs and a focus on arrhythmias. Part two, which will delve into ST and TV wave abnormalities, is scheduled for next week. We'll confirm the exact date soon, inshallah. We are privileged to have with us Dr. Adan AbdiJabar, a senior internal medicine resident at KNH and the founder of Peace Medicine. We are truly honored to have him here to share his expertise and guidance. Without further ado, please join me in welcoming Dr. Adan AbdiJabar.
Thank you, Abdullah, for the kind words. Thank you, Msaoun, for the kind invitation, and Najib for the prayer before. So a disclaimer, and it's hardly difficult, it's hardly easy, I mean, to do ECGs on one session or two sessions. We just did a session with the Kenya Cardiac Society, which lasted about 8 weeks, doing different aspects of the ECG. So when I was given this topic, it was difficult to see where to start from and where to end it. And number one, because the topic is wide. Number two, because the audience has different levels of understanding of ECGs. So if you start from the beginning, you might bore some people. If it starts from the middle, you might lose some people. So I've tried to do some justice here, where we've tried to combine the basics of ECG with some advanced ECG. So, like Abdullah said, this will be a two-part series. Today, we're looking at the introduction to the ECG plus some arrhythmias, especially the bradyarrhythmias. And then later on, next week, we'll do the tachyarrhythmias plus STT wave changes. So without further ado, let's dive into this topic. So all of you are remember Eindhoven, and this is the first ECG ever to be recorded, and this is how it looked like in lead one of the ECG. So, and this is it. This is our normal ECG, the one that we have usually at the that we conduct from the patient. This is how it looks like. So from there on, the black and white picture to today, what we have, this clear picture, is how far the ECG has come. And the other thing is the initial ECG was bulky. Over the years, it became more portable, and with more portability, and right now we have wearable devices that can check your rhythms. So we've come far from far. So before you understand ECGs, you have to look at the cardiac physiology, and it's important to understand that before you delve into the ECG, and that's what we'll tackle for the next few slides before we go straight to ECGs. So remember, in the cardiac cycle, there's the electrical event, then there's the mechanical event. The electrical events precede the mechanical events. The mechanical events basically are the contraction and the pumping of blood from the ventricles to either the lungs or to the systemic circulation. So what happens is you have this electrical activity, and that starts from the sinoatrial node, and then there's atrial depolarization, goes to the AV node, and then it goes to the His bundle, all the way to the Purkinje's, via the left bundle and the right bundle. Then it goes to the Purkinje's, and then there's depolarization of the ventricles, and then the ventricles contract as a result of calcium influx to the cell. And then you have exit of blood or efflux of blood via the AV, via the aortic valves and the pulmonic valves into the lungs and the systemic circulation, respectively. So in the heart, we have two types of basically cells. We have the non-pacemaker cells, that is the normal cardiac myocyte, and the pacemaker cells. And in the pacemaker cells, they have this hierarchy, which is informally called the pacemaker hierarchy, where you have the sinoatrial node, which is sitting atop of that hierarchy, and then you come down to the AV node, and then you go to the bundles, and then you go to the Purkinje fibers. All of them have different conduction. So SA node has the highest conduction, has 60 to 100 beats per minute. Then you have this AV node, then you have the bundle branches and the Purkinje. So if there's a problem in either of each, and then the pacemaker activity moves to the next. I.e., if you have a problem with the sinoatrial node, then you'll have an atrioventricular node that is going to take over the activities of the pacemaker in such a way that you'll have a nodal sort of activity rather than the SA node activity. And then below that, you'll have the Purkinje fibers, which will take up the role of the pacemakers. So you'll have what is known as an idioventricular rhythm if the Purkinjes are the ones that are firing. All right. So the normal cardiac myocyte, remember that the myocytes are a syncytium. It's not one single muscle. There are several muscles that have end to end together, side to side together. So they are slow conduction from cell to cell. So there's depolarization of the muscle, then it moves on to the next cardiac myocyte. But the initial activity is the spontaneous activity from the SA node that When that depolarizes, it moves to the cardiac myocyte. And when there's an electrical event, we'll see that in the next few slides. So this is what happens in the electrical events of the heart. There's the SA node that fires first. Then you have the atrial muscles. And then you have the AV node that fires and concentrates the impulse for a few minutes to allow the atria to contract, so that you have the atrial kick, which drains the blood from the atria to the ventricles. And then later on, there's movement to the His bundle, and finally to the bundle branches. Let me use this highlighter pen. So these are basics. So these are the bundle branches, and then finally the Purkinje system. And the red line is the cardiac axis. That's how the mean vector of the cardiac axis is moving. So that's basically it for the electrical events of the heart. So the cartoon upwards just shows you how the normal movements are. So the SA node to the internodal pathways, the right and the left atrium. Then there's a slow delay in the AV node for a few 40 milliseconds. And then it moves towards the His bundle, and then the right and the left bundle branches, and then finally to the Purkinje cells. And then you have the mechanical coupling, where you have, initially you have the tricuspids and the mitral valves that are closing, and then you have the contraction of the ventricular muscle, and then you have the opening of the aortic valves and the pulmonary valves that leads to draining of blood from the ventricles. So how does cardiac potential arise from? So generally you have three things that lead to the potential. It's the movement of ions leading to the transmembrane potential. And then you have this, the excitation contraction coupling. So in the resting cardiac myocyte, you have the resting potential at negative 90 millivolts. That is, the predominant ion at that time is the potassium ion, where there is a slow movement, net movement of potassium from where it's highly concentrated inside the cell to outside. So this maintains the cardiac myocyte at negative 90 millivolts. And then you have these other ions that come about that we'll see, the sodium ions and the potassium and the calcium ions that change the transmembrane potential. So these events lead to the electrical excitation and finally the cellular contraction. So this is basic physiology, second year physiology. The potassium is the predominant ion intracellularly, and it's at 150 millivolts, and then it moves to the outside of the cell. It's about 4. So the potential, the potassium ion potential is at negative 96 millivolts, which is close to the cellular transmembrane potential. And then you have sodium, which is concentrated outside, and which is low on the inside, same as calcium. So at the resting membrane potential, you have potassium that is slowly leaking from the cells and maintaining the cell at that potential at 90 millivolts. So at sodium, for that positive charge of sodium to lead to equilibrium between outside the cell and inside the cell, you require an external stimulus, such as an electrical event that will lead to a gross movement of sodium from outside to inside, same as calcium. So what contributes to this potential is these pumps, which are the sodium potassium ATPase. So as the potassium moves out of the cell, it's taken back inside the cell in such a way that there is a cycle of movement to maintain the cell at that negative 90 millivolts. And you have this sodium calcium exchanger that also works, and the calcium ATPase that maintains the cell at that level. So what happens in the different phases of the action potential of the cardiac myocyte? At phase 4 is the resting phase, which we have talked about, where you have negative 90 millivolts. Potassium is the predominant ion there. and there's a net movement of potassium from inside the cell to outside the cell. That is, the inside of the cell is negative relatively to outside the cell. That's why the transmembrane potential is at negative 90 millivolts. Then you have an action potential that arises from the pacemaker in the SA node, and then you have these sodium channels which are recruited. So you have this first phase 0 where you have sodium channels that are opening, and you have a large amount of sodium that is coming inside the cell. Then it goes above what you know as an overshoot, above the 0 millimole of 0 millivolts, and then in phase, yes, okay. So in phase 1, yes, you have the transient potassium channels start to open, and where you have now, and if you'll have now you're getting the repolarization phase. But in phase 2, there is a sort of balance between an influx of calcium channels and the influx of potassium ions, leading to a plateau phase. And finally, when the calcium channels close, you have these delayed rectifier potassium channels that are open, leading to influx of potassium through the ions, and then return of the cell to the phase 4, which is the resting membrane potential. The pacemaker potential is a bit different from the cardiac myocyte. They don't have a true sort of phase 4. They always, in phase 4, the pacemaker potential is already depolarizing. And so it's not really at rest. So it's already depolarizing slowly. And the main channels that are occurring there are called the funny channels. Funny because they are sodium channels and potassium channels together. And also the sodium channels, and they're working at negative 60 degrees, negative 60 millivolts, which usually sodium channels don't work at that level of negative charge. So they're working in the background, leading to a slow depolarization. And then when you reach about negative 50 millivolts, then the calcium channels start to open. Initially, the transient calcium channels, and later on, the long-lasting calcium channels start to open, where you have now rapid influx of. And then later on, now you have the efflux of potassium in phase 3, leading back to repolarization of the cell. So note that the pacemaker potential, or the pacemaker cells, don't have phase 1 or 2, and they don't really have a predominant sodium influx. What occurs more is the calcium influx that leads to the depolarization. So side-to-side comparison, this is what happens. They have a higher threshold, the pacemaker potential is higher. They don't really have this, they have a slow phase 0 as opposed to the cardiac myocyte. They don't really have this phase 1 and phase 2. And so these are the differences between the pacemaker and the cardiac myocytes. So what happens in impulse generation and propagation? So you have the synoatrial node and has the spontaneous impulse generation, and then this impulse activity moves to the cardiac myocyte, which is a syncytium of cells, moves through gap junctions. And then what happens is when in phase 2, when there's calcium influx, so you have the sarcoplasmic reticulum, which allows this calcium influx to go into the cell, and then the actin-myosin complex occurs. Then you have this contraction of the heart. So contraction occurs in phase 2 of the cardiac myocytes. So we have seen this. It's a summary of what we've discussed so far. Basically is how the action potential moves through the different parts of the heart. So this is a summary as well of the whole cardiac cycle. So in diastole, and you have passive phase filling of the ventricles. And then when that occurs, you have what is known as the isovolumic relaxation, where you have a relaxation of the ventricles, and then there's volume that is coming in initially passively, and then later on the actual kick comes in. So the initial part of systole, there is a contraction of the ventricles, then there is abutting, there's closure of the tricuspid and the mitral valve, where they abut towards the atria. Now the next thing that occurs is there's increased pressure in the ventricles, such that let me see. So if you look at here, so this is the aortic pressure. Initially, the ventricular pressure goes above the aortic pressure, and that what leads to that is they open the aortic valves and the pulmonic valves, and they lead to an efflux of blood or pumping of blood through the aortic valves. So as the volume in the ventricles reduces, the pressure in the ventricles reduce, and the pressure in the aorta increases. So when the pressure in the aorta increases, what happens is there's closure of the aorta, the aortic valve leading to the lab dub. So the dub is the closure of the aortic valve. So this is the whole cardiac cycle that is represented here. So this is just a representation of the same that you've just seen. So what happens is the electrical activity occurs first, then this goes all the way to the Purkinje fibers, where you have the ventricles that are depolarized. And the first thing that occurs, if you look at this diagram carefully, is the tricuspid valves close, and then the ventricles contract, leading to opening of the aortic valves. And then later on, they relax. When they relax, that means that the aortic pressures are higher now than the ventricular pressures. When they relax, the tricuspid valves open, and then you have passive movement of blood from the aorta, from the atria to the ventricles. So this is the ECG basically. So the P wave is atrial depolarization, and then you have this TR interval. So this the beginning of, and the P to the beginning of the R is the movement of the electrical impulse all the way to the Purkinjes. So that's the PR interval. And then there is a wave that is not represented here, which I'll discuss later, is the atrial repolarization wave. Is not represented in the ECG, but there is a wave, there's a name for it. And then the next thing that you have is the QRS complex, where you have the ventricular depolarization. And then you have the ST segment, which is an isoelectric line. That means all the muscles in the heart at that time are relaxed. And then you have the T wave, which represents ventricular repolarization. Basically, the P wave, from the middle of the P wave is where diastole starts, right? So we have atrial depolarization, we have ventricular depolarization and repolarization. So what we don't have in the ECG, the untrained eye, is the atrial repolarization. So the atrial repolarization wave is known as a tau wave, TA, tau wave, and it's buried in the QRS complex. So later on, in your studies, you'll see when you go into depth, the tau wave, which is an atrial repolarization wave, which is buried in the QRS. So these are the normal limb leads, normal leads of the heart and how they are placed. So you place the limb leads in the right hand and the left hand, signifying the right atrium and the left atrium. And then you put another one in the left leg, and then the right leg is the earth. And then you have the chest or anterior leads, which go all the way to the anterior axillary line. And so you have V1, V2, V3. So you have 6 limb leads, and you have 3 bipolar limb leads, which are lead 1, lead 2, and lead 3, and 3 unipolar leads, which are AVR, AVF, and AVL, which makes the 12-lead ECG. So 6 precordial leads and 6 limb leads. So these are the limb leads. The bipolar leads, which are the lead 1, lead 2, and lead 3. Bipolar meaning that there's a physical negative pole. Sorry. There is a physical negative pole and a physical positive pole. So there's a net movement in lead 1 of movement from the right arm to the left arm. Basically, the lead 1, although it moves laterally, is like looking at the heart from top. And then you have lead 2, which has a net negative from where it's starting to the recorder, which is at positive. And then you have lead 3, which also is a bipolar lead, physical bipolar lead, moving from the left arm to the leg. And then now you have the augmented leads, which theoretically are unipolar leads. They share the same electrons as the limb leads, but they are, so to speak, their axis, or where the polarity is in relation to the other leads. If you look at the AVF here, the polarity of AVF is in relation to lead 1 and lead 2, sorry. So, but theoretically, the area of departure, or area where the axis comes from, we call it somewhere in the middle of the heart. That is what the axis is used for. If you look at AVL here, so in between lead 1 and lead 2 is where the AVL is. And if you look at AVR here, the 2 leads, in between these 2 leads is where the impulse starts from. So the normal limb leads are bipolar and augmented limb leads are unipolar. So just a recap of impulse generation. And if you look at, so the initial impulse starts at the sinus node, occurs just before the P wave. Remember, the P wave is atrial depolarization. So the impulse is generated, and then the impulse moves to the atria. When the atria are depolarized is when you have this bump of the P wave. Somewhere in the middle is where the impulse goes to the AV node, where there's slowing of the impulse, so that you have the atrial kick that leads to blood moving from the atria to the ventricles and the atrial relaxation. And then finally, it goes all the way to the Purkinje fibers. So all this, and by the time it reaches the ventricular muscle, it has gone up to 200 milliseconds. So when we say that the normal PR interval is 0.2 seconds, it's not theoretical. It is how the impulse moves. It's the duration of the impulse movement from the sinus node all the way to the beginning of ventricular depolarization. That is the R wave. So that is the distance of that's the distance of the PR interval, and the reason for its depiction at 200 milliseconds. So that is the basic sort of cardiac physiology of the basic understanding of the ECG. Now we go to the meat of the matter, the ECG itself. So when you're looking at the ECG, there is a systematic way of reporting it, or a systematic way of understanding. So the first few things that you look at is the general impression of the ECG. You look at it, you eyeball it. What do you see? Do you see a fast rhythm? Or do you see a slow rhythm? Is it chaotic, non-chaotic? Okay. Some others will go as well to all the way to say it's beautiful looking ECG, if it's a normal looking ECG. You know, ominous if you see these ST wave changes and so on. So that's a general impression of what an ECG is. The next thing that you look at is the calibration of the ECG. So if you can see here, so this is the general impression. And then the next thing you look at is the calibration. Calibration means the axis or the scale of the ECG. So the scale, like, all maps have scales. So this is the scale of the ECG. You look at any ECG that you look at the end, you'll see the calibration. And then the next thing you look at is the rhythm and the interpretation. Is this a sinus rhythm or you have an arrhythmia and so on? And then after you're done with that, you look at the QRS complex. The QRS complex, you want to look at an R wave progression, how the R wave moves from V1 to V6. Then you look at the axis, all right? And then you look at whether there is any bundle branch block and so on. And then part of the initial assessment, you look at whether there's atrial hypertrophy or ventricular hypertrophy. And then finally, you come to the ST changes, ST-T wave changes, and then the T wave. So this is the systematic approach or reporting for ECGs. So the first thing you look at, basically, you look at the general impression of the ECG and the calibration and the rhythm. So that's what we'll discuss tonight. And then in the next sessions, we'll discuss these other components of the ECG. So ECG is not guesswork. It has, ways to report it, and that's what we're going to look at. So the calibration of the ECG. Generally, the general impression of the ECG is what you look at. So the slow, fast, ominous, or looks normal or beautiful looking ECG. That's what we say. So the ECG paper, the machine that is printing the ECG, has different speeds. So the standard speed is 25 millimeters per second. So for 1 second, the ECG prints 25 millimeters of paper. Okay. So when it prints 25 millimeters of paper per second, then we derive some calculations out of that. All right. So the calculations that we derive out of that is that in one, so if the 25 millimeters per second, 25 millimeters is equals to 1 second, so we say 1 millimeter will be how many seconds? So 25 millimeters equal to 1 second, so it will be 1 over 25. 1 over 25 is 0.04 seconds. So one small little tiny box is 0.04 seconds. Basic mathematics. So the large boxes. So this is a tiny box. The large boxes. So this is a tiny box. Sorry, this thing is. So this big box has 5 tiny boxes. So each small tiny box is 0.04 seconds or 40 milliseconds. If you multiply by 5, it becomes 0.2 seconds. So one big box is 0.2 seconds. So the standard calibration for ECG is 1 big horizontal box and 2 big boxes vertically. So the 2 big boxes vertically, those are 10 millimeters, okay? So one small box is 1 millimeter, and one big box and 5 small boxes. One big box is 5 millimeters, and then 2 big boxes are 10 millimeters. So in the vertical axis, 1 millivolt is equals to 10 millimeters or 2 big boxes, such that if you look at the end here, you have one small box, one big box, horizontally, and 2 big boxes vertically. So that is the standard calibration of the ECG. So if you look at it, you say this is the standard. The ECG is of standard calibration, and you move on and you go on and report the ECG. So some ECGs have different speeds. Some will have 50 millimeters per second. So what happens is there is slowing, okay, of the ECG. You think it's slow, but actually it's just because of the speed. That's why it's important to look at the standard calibration. So you have different milliseconds when it comes to if the speed were to be faster or the speed were to be slower. So the standard ECG, that's what I was talking about. Just a repetition. So the small box is 0.04 seconds, and the large box is 0.2 seconds. So the ECG, the whole ECG, one strip of ECG is a 10-second strip. The whole ECG, like if you have a whole paper, that is a snapshot of your heart or the patient's heart for 10 seconds. All right. So for us to have looked at the ECG for a minute, then you'll multiply that by 6, and we'll look at that differently. And then this is what I was talking about, the standard calibration. And this is basically what we've said. So 25 millimeters is 1,000 milliseconds, which is 1 second. So one small box is 0.04 seconds, and one large box is 0.2 seconds. So basically it's, if you look at it's 25, it's 25 divide by 1. And then if you look at that, then you can get, 1 over 25, then you get 0.04 seconds. So how do you calculate the rate? The different ways of calculating the rate, you can use the large squares or the small squares. So if you use the easiest method for someone who is starting is to look at the ECG if it's regular. If it's a sinus rhythm ECG, you know that the whole strip of the ECG is 10 seconds. So what do? You know that what you're going to do is that you're looking at the R interval. That's, the R is when the ventricles are contracting. That's when you get your beat. That's what, so every R is the beat of the heart. So in this ECG, let's say, these are 10-second strips. So you have 1 R, 2 Rs, all the way 9 Rs. That's 10 seconds. For you to know how many beats you have per minute, you multiply this by 10. So that is the easiest method if you're starting to report ECGs. The other method is you calculate the number of big boxes. These are the big boxes. And then you divide by the number of Rs that you have. So if you have if you have 300, if you have 5.4 large squares, then one big box is the number of boxes that they have in the ECG strip, and the whole ECG strip is 50. So if you multiply that by 6 for a whole minute, you will have 300 big boxes. So you use 300 boxes, divide by 5.4 and squares. The difference, how many squares that are there in the between R's. So let's say this one, these are 2 R's. So 1, 2, 3, 4, 5, and about 3 thereabouts. So 4. So 300 is the number of squares, that big squares that will be in 1 minute, and then you divide by the distance between the R's, and then that's the heartbeat or heart rate that you'll get. The other one is, now you can use small squares, the small tiny ones. So in 1 minute of the heart, you can have 1,500 tiny small squares, and then you divide by between the 2 R's how many, and between the 2 R's how many small so that is 7, then that becomes 6 per minute. But now with you advance in the ECG, then you can use this method, the method that is enlarged here, where you look at the ECG, you look at how many big boxes are there. If the ECG between R and R, the whole ECG had, and every box had an R, so that is basically 300 beats per minute. Okay, so that is so the first box, you say that is 300. You move on, you say if there are 2 boxes, you say 150. Then if there are 3 boxes, you go to 300. If there are 4 boxes, 75, 60 beats per minute. So you look at it, you eyeball it, you see one. So you come here, it's 0, 300, 150, 100, 75, all the way to 60. But that is for more advanced level. So if you're starting it right now to look at ECGs, then the first thing that you should look at is this one, where you look at the number of R's and then you multiply by 6, and you multiply by 6. Okay, what if, so this assumes that you have, a regular. However, when you have an irregular rhythm, where you either have blocks or you have fast rhythm that is irregular, then you can't use the normal rhythms. So what you do is you count the number of R's, that's the number of beats, for a 6-second strip. 6 seconds is about 30 boxes. So I told you the ECG is a 10-second strip. The ECG, the whole box is 50, but you count for 6-second strip and you multiply by 10. And that is how you use and how you calculate the rate in patients who have an irregular rhythm. So we look at conduction abnormalities. So conduction abnormalities are either bradycardia, slower than 60 beats per minute. Some authorities use 50 beats per minute. And then you have tachyarrhythmias, which are above 100. And then they have different levels of where they arise from. So bradyarrhythmias, when we look at tonight, we're looking at the SA node. Is there in the SA node? You're looking at the AV node. Is there a pathology in the AV node? And then you're looking at the His-Purkinje system or the bundle branch in the His system. Okay, so let's look at the sinus node dysfunction. The reason why I put it here is that it's not usually taught. The reason why is because it can be complicating, and it's not usually taught. So you go out there not knowing what a sinus node dysfunction is. So it's just better I'll just gloss over it, and then we'll look at the one that is mostly taught at undergraduate level. So you look at sinus arrhythmia, which is the heart is in sinus rhythm, but because of changes in the respiration, you have these beat-to-beat changes of the heart because of the changes in respiration. Then you have a sinus pause arrest, which we'll look at that. And then you have this, what is known as a brady-tachy syndrome, where the heart sometimes will have bradycardias and then we'll have tachycardias. So the reason why sinus node dysfunction can occur is because of age-related, because of AFib that has occurred for a long time, that has led to remodeling. You can have blockage of small feeder artery to the SA node, and then you can have these other reasons that is in the slide. So a sinus pause or a sinus arrest. So basically, what a sinus node dysfunction will lead to is a pause in the rhythm. So you have these nice looking PQRS complexes, and then after a while you have the silence, the pause. So when you have a sinus pause is between 2 to 3 seconds, but when you have an arrest is more than 3 seconds. You have a sinus arrest. Basically, is what you see on TVs, where you have beat to beat and then there's silence. So it's difficult to differentiate between a sinus arrest and a cardiac arrest. But sinus arrest, you have 3 seconds and then you come and the rhythm is back on, as opposed to cardiac arrest where you have loss of rhythm at all. So, and you have sinus node exit blocks, which are the same as the AV blocks. The only thing is here, instead of a QRS that is dropped, it's a P wave that is dropped. So here you have a P wave, you have a P wave, but as they come, then there's a drop in the P wave. Then you have this P wave, right? So in the first one, and I don't need to go to that, but generally know that you have these drops of P waves that occur and in the different types of the exit blocks. So the AV blocks, so the AV node, like we talked about, delays the impulse for about 0.04 seconds, that is 40 milliseconds. And then the other thing that occurs is it's a subsidiary impulse generator. We talked about the pacemaker hierarchy. If the AV node does not work, then it kicks in and takes over. And then finally, it limits ventricular rate. If you have AFib that is fast, then the AV node tries to limit that rate to be taken towards the ventricles. So the spectrum of AV blocks, you have an incomplete block and a complete block generally. So the first one, the first type 1 AV block is it's known as a first degree AV block. We'll look at it, and then you have the second degree, which has different layers. You have the second degree Morbitz type 1, second degree Morbitz type 2, and then you have a high grade block. All right. So the first degree is when you have a prolongation of the PR interval. So the PR interval is the interval from the beginning of the P to the beginning of the R. So that is, remember we said it's about 200 milliseconds, all right? So that is 0.2 seconds. And the reason for that is that's the amount of time it takes for the impulse to go from the SA node all the way to the PNG. So if that is prolonged, then you can have a block at any level from the AV node. So you can have a block at the AV node. You can have a block at infranodal, which means below the AV node. So you can have at the His bundle, that is called a Hisian block. And then you can have bundle branches, that's called a bundle branch block, all the way down. Those are the blocks that you can have. So in this one, the first AV block is just a prolongation of the PR interval without any drops. So that means that there is slowing of the impulse in the AV node, but an impulse is still propagated to the ventricle. So there's no impulse block. There is slowing, but there's no block. And the way to know it is that it's longer than 0.2 seconds. The QRS is normal. It's not a wide QRS. So this is what an example of a first degree block. If you look at this, so the best way to know it is if by looking at by eyeballing, if you see the P waves are outside the big box, then you know that this is more than 0.2 seconds. So, but the easiest way is also you look at the interval and you calculate. Remember, and the smallest box is 0.04 seconds. So, and the normal one, it will be about 5, but this is it's about 6. So it's longer than the normal PR interval. So remember, this big box has about 5 small boxes, which are 0.2 seconds. So the P wave, the beginning of the P wave, it's outside that. It's about 3 boxes outside that. So this is first degree AV block. It can be physiological in young patients, in athletes, and who are in high performance, athletics. They can have this first degree AV block. It's generally benign, and it's not treated. It's not managed. The second degree AV block has 2 types. Type 1 is also known as the Wenckebach phenomenon, and then type 2. Type 1 is usually reversible, occurs because of vasovagal increased vagal tone, or because of certain types of drugs, and it occurs in inferior MI, and because of the edema that is associated with that, and so the inferior MI occurs because of a right coronary artery block or a right coronary artery atherosclerosis. The right coronary artery supplies the AV node. So the AV node has dual supply from the right coronary artery and left circumflex. So if the right coronary is blocked, then left circumflex continues to supply that. So it's usually, in terms of the block that it will cause, it's usually benign and transient. as opposed to type 2, where the block is below the AV node, is the Hessian block or infranodal. So the His bundle does not have dual supply. So when that is blocked, then what you get is a permanent sort of AV block, as opposed to the transient that we see in inferior MI. Okay. So the location of the block in type 1 is AV node, in type 2 is infrahessian, Hessian and infrahessian. So that means the His bundle and below it. So what happens is, remember I told you that you have hierarchy of pacemakers. So when the AV node is blocked, when the AV node has issues, then you have a junctional rhythm. The junctional rhythm is about 40 to 50 beats per minute, okay? So what it has is that any rhythm that is coming from anywhere above the AV node has a narrow QRS. Any rhythm that comes from anywhere below the AV node, that is from the ventricles, then you have a wide QRS complex. Okay, and then the type 2, like I said, is permanent. And what it has is when you have a block below the His bundle, then you have an idioventricular rhythm. The idioventricular rhythm is the beats are between 20 to 30 beats per minute. So the second degree AV blocks, like we said, Mobitz type 1 and type 2. Mobitz type 1 is actually the AV node block, like we saw, and the Mobitz type 2 can occur anywhere. It's a Hessian block, which is an infranodal block, and then in these bundle branches where it can be infrahessian. So this is the His bundle. This is the left bundle. It has an anterior fascicle and a posterior fascicle, and then the right bundle is just single. So when you have one block, it's called a bundle branch. When you get both blocks are called the trifascicular block, where you have all the fascicles that are blocked. So the Mobitz type 1, which is also known as Wenckebach, what happens is let's say a student is a latecomer, and every time he arrives late to the bus station. So every day, the first day he arrives 10 minutes late, the next day he arrives 10, 15 minutes late, the other day he arrives 20 minutes late. The fourth day, the driver gets pissed with him and leaves him. So this is what happens in Mobitz type 1. So initially, the PR interval is normal. The student comes in time. Then the PR interval becomes long. So the PR interval becomes slightly long, then goes slightly longer, and then this is dropped QRS. Okay, so what you used to call it longest drop. So you'll not have it that way. You'll not have all three. So you have to look at, and is the PR interval long, and is it increasing in length, and then does it lead to a block? So you have to look at a PR interval prolongation, and then leading to a block. So this is what is known as a ladder diagram. How the PR interval leads to a QRS complex. So if you look at this, the initial PR interval, the P1, it's a 0.2 seconds, so that is normal. Then prolongs to 0.32, then prolongs to 0.38, then 0.40, and then drop. Basically double of normal and then drop. So the other things that are very technical, maybe not at your level, is that the delta, the change in elongation becomes smaller as you go on, but the length is large. So you get a drop. So what you need to know in clinical practice is that there is longer drop. So that is what you need to know in clinical. The rest is just academic. So you have this that is long, then you have this that is longer, and then you have drop. So you see this ladder diagram. This is long, then this is longer, 300 milliseconds, 380. Then the ladder diagram you showed, there's a P, but then there's no QRS complex, it's dropped. So the same here, P wave, then drop. P wave, then drop. So that is Mobitz type 1. So you can have different ratios in terms of the number of P waves. So you can have ratio A to B. So A is the number of P waves, B is the number of QRSs. All right. So if you have a normal, normal rhythm, you have then the same number of. So you have the same number of P waves, and then you have the same number of QRSs complex. But let's say, for example, in the first, for instance, in the first one, you have you have two P waves, so two P waves here, but you have one QRS, so that is a 2-to-1 ratio. So you have two P waves to one QRS ratio. All right. So you have two, and here you have one P wave, another P wave, and then you have another P wave, and then a drop. So this is 1, 2, 3, okay, and then this is the P wave. It's abutting the T wave. So this is 4. All right, 1, 2, 3, 4. So those are 4 P waves, and then there's a drop. So that is, and then you have this, how many QRS complex? 1, 2, 3. So it's 4. It's a 4-to-3 ratio. So we came from a 2-to-1 ratio to a 4-to-3 ratio. If you look at this one, you have 1, 2, 3, 4, 5. So, and then 6. So you have 6 P waves. How many QRSs do you have? 1, 2, 3, 4, 5. So that's a 6-to-5 ratio, so on. So this is how you so the second degree AV block Mobitz type 2, the reason why apart from the morphology that is different, there is a real clinical and there's a real clinical and application of whether it's Mobitz type 1 or type 2. In Mobitz type 1 is basically conservative management, as opposed to Mobitz type 2, where you'll consider the patients to get a pacemaker. So those are the clinical characterization or indication. So it's not just morphological. We're saying is Mobitz type 1 or Mobitz type 2. There is a real life impact on that decision that you make, whether it's Mobitz type 1 or Mobitz type 2. But the difference between Mobitz type 1 and Mobitz type 2 is that the PR intervals don't lengthen. Okay. So this is not a problem in the AV node. It's not the AV node that is trying to lengthen the PR interval. So this is a problem after the AV node. So what happens is it's a normal PR interval, and then there's a drop. So you have a normal P that is not long, and then you have a drop. The drop just appears out of nowhere. Then you have this one, then a drop appears out of nowhere. So then the other thing is the QRS is large or it's wide. So what happens is, where I told you, if the QRS is occurring or is being propagated or is occurring in the ventricles, then it becomes a wide QRS, as opposed to the atrial. If the impulse is coming from the atrial, the QRS is slower, is narrower. So this is a Mobitz type 2 ECG. So if you are to look at the ECG, generally you look at and look at and this far end, you say this is a standard calibration ECG. So you have two big boxes that are going up, and then it's not clear, but one box horizontal. That's a standard calibration ECG. If you look at general impression of the ECG, it looks a slow ECG. And then you come here, you look at the rate. So usually in the normal ECG, they give you a rhythm strip, which is the lead one is the rhythm strip. So you come here and you look at this. So you say this is zeros, you say 300, 150, 100, 75, 60, 45, 50, about 30. Then the other way you can calculate is how many big boxes are here? 1, 2, 3, 4, 5, 6, 7, 8. That is 300 divided by 8. About 37.5. So I was thereabout. The other way you can divide this, you can look at this is, and so this is an irregular rhythm. So the best way to look at it is look at a 6-second strip. That means you're looking at about 30, you're looking at about 30 big boxes here, and then you multiply by 6. So that is how you get the rate in such ECGs. So the other thing that you look at is rhythm. So you look at this, is it a sinus rhythm or not? So, and some rhythms have a P. So the way to know whether the sinus is a sinus rhythm, every QRS complex is preceded by. So in this one, you have some QRS complexes that are preceded by P, and you have one QRS complex that is dropped. All right. So you say that this is an arrhythmia. It's an arrhythmia, and you try to find out what type of arrhythmia that you have. The arrhythmia that you have, there's no regularity. If you take the best way, take a paper and you calibrate the paper at the beginning here and at the end here and at the beginning here and the end, and you push the paper. You move the paper and you see if there is regularity or not. So this is an irregular rhythm. The other thing that you come and you check is the P wave PR interval. You look at this PR interval, it looks the same. PR interval looks the same. Now there's a drop. So here, you have a P wave, then there's a drop as well. Then you have the PR interval here, same, PR interval here, same, drop. PR interval here, same, PR interval here, drop. So this is, you have one P wave here, another P wave here, another P wave here. So you have 3 P waves to 2 QRSs. So you have a 3 to 2 drop. So because the P waves are not elongating or are not, this is the type 2 Mobit and AV block. We're coming to the end of the presentation. So we have this to a complete heart. So you treat them as the same way you'll treat a complete heart. So that's an adjunct implantation. So 2nd degree AV block with a high have two or more of P waves that are not conducted. So if you look at this, you have a P wave here, it's not conducted. You have another P wave here, it's not conducted. Then you have another P wave here, which is conducted. So you have 3, 1, 2, 3, and then you have 1 QRS. So you have a 3 to 1 ratio of this second high degree AV block. So there is a scenario. I don't know whether it's an undergraduate scenario, but let's say you have a 2 to 1. You have 2 P waves, and you have 1 P wave. So you have 1 P wave, another P wave here, and you have 1 QRS. Because there are no preceding P wave or preceding complexes, you don't know whether this is a type 1 or a type 2. Because for you to know whether it's a type 1 or type 2, you will need to know the preceding P waves, whether they were elongating or not. So if they were elongating previously, then you'll have said that this is a type 1, Mobit's type 1. If the PR interval was normal, you'll have said this is a Mobit's type 2. But there's no way to know that because there's no preceding complexes. So the best way to know is you look at the PRS complexes. If they're wide, that means the problem is below, is in the ventricles. So you say these are 221 AV block with a wide QRS, likely a Mobit type 2, which is an infranodal or infrahesian. And then you have, when you have a narrow QRS, then you say that this is type 1 AV block. Okay. So this is another type 1 AV block. Look at the QRS there, narrow. So this is a type 1 AV block. And so you have a P wave QRS, then you have a P wave, then there's a drop. You have a P wave QRS, so you don't know and before the drop, if they will have other complexes occurred, you'll have compared. But now you can't compare. So you can't say longer drop. So there's no longer to compare it with. So this is long, but the QRS is narrow. So you say this is a type 1 AV block. A complete heart block is when what is known as when you have an AV dissociation. The atria and the ventricles are completely incompatible. So they're not married. The atrias are contracting on their own, the ventricles are contracting on their own. So you have a dissociation. The atria is dissociated from the ventricle. So this is what happens usually. You'll have a P wave that is conducting on its own, and you have a QRS that is conducting on its own that is different. So you have this P wave now, there's another P wave here. It's not related to the QRS. You have a P wave here, you have a P wave that is almost here. It's not related to the QRS. So they are being conducted independently. So that is our final slide. We will stop there and we'll take questions, and if someone has any question. Abdullah, back to you.
Shukran, Doc, for the wonderful presentation. If anybody has any question, kindly feel free to unmute or type in the chat box.
Doc, could you kindly repeat the ratios you were talking about for the second degree heart block? The 3:1 and the 2:1.
No problem. Just give me a minute. 1 second. So the ratios. Let me look at the ratios. So the ratios are, so alpha to beta. So alpha is the number of P waves that are propagated, and beta is the number of QRSs that are propagated. So usually because you're dropping a QRS, the number of P waves are more. So the P waves are being propagated, but somewhere in the AV node or in the His bundle, they get lost and then there's no QRS. So you'll have, let's say in the first one, this one, you have this P wave, you have another P wave, but the QRS is dropped. So you have 2 P waves and 1 QRS. That's a 2-to-1 block. And then this other one, you have a P wave here, you have another P wave here, you have another P wave here. So those are 3 plus another one here on top of the T wave. So those are 4. But the QRSs, you have 1, 2, and 3. So that is a 4 P waves and 3 QRSs. So it's a 4-to-3 block. So it's so the initial one is, first of all, you need to find out whether it's a type 1 Mobitz or type 2 Mobitz. After you do that is when you do the ratio. So you say it's a 4-to-3 type. Let's say let's look at this one. So this one, the PR interval it's at the margin. Now it's getting longer. Now it's getting longer, and then there's a drop. So you say it's a Mobitz type 1 and 4-to-3 ratio. So 4-to-3 ratio Mobitz type 1 AV block. Is that clear?
Yes, it is. Thank you.
Hello. Hello.
Yes, go ahead.
Yeah, thank you, Dr. Adan. I have a question about the R-wave progression. Would you mind repeating about the R-wave progression?
I didn't tackle it, but generally R-wave progression is, it starts from a negative or a biphasic V at V1, And then at V3, there is, so you start at negative in V1, and then at V3, you have a biphasic. I don't know if I have a, oh, okay. So generally, so this is someone who might have an RBB. Generally, what happens in V1, you have a negative deflection, all right? And then somewhere in V3 here, you have a biphasic. Biphasic meaning you have the downward deflection and the upward deflection are basically almost equal. And then V4, you still have some biphasic. Then you have V5 and V6, which have an positive upward deflection. But if you look at this patient, they also have RBB. That means right bundle branch block, where you have this M-shaped sort of in the V1. But that we'll discuss if you have time in the next discussion. So this is when you have a poor R wave progression such that you have a biphasic or you have a positive deflection in the V1, then you're thinking there's a problem in the right ventricle, either a right bundle branch block or a right ventricular hypertrophy that is causing a poor R wave progression.
Okay, thank you.
So it's when you're covering a lot of basics, it takes a lot of time. So in the next session, now that we have covered the basics, in the next session we'll go to the details of the different pathologies, and you have to cover the basics so that at least people understand where we're coming from in terms of ECGs. There are two questions that we've posted in the chat. Kindly attempt them. It's a poll in the PaceMed Twitter page. So go to the PaceMed Twitter page, attempt the questions, follow us, and then after the closure of the poll, we'll write the results of what the ECGs had in those patients. So yeah, so they're there in the chat. Let's see the votes coming in, and these are the questions we just discussed. So they're not strange. They're not strange. Actually, it's the easy questions. We didn't want to make it difficult the first night of ECG presentation. I want you guys to learn ECGs. And on top of this, we did let me see. We did presentation for the Kenya Cardiac Society. If you go to the Kenya Cardiac Society webpage, you'll see the presentations that we did over 8 weeks of the different how to interpret ECGs from A to Z. So you look at different presenters, you look at that. Okay? So in terms of when you should do an ECG, you can do it as routine evaluation. If someone has palpitations or arrhythmias, if someone has syncope where there's loss of transient loss of syncope, where they have dizziness and so on, dyspnea, and if you do a preoperative assessment or you're having electrode abnormalities. So those are the reasons for doing ECG. But now ECG is becoming commonplace. You have to, and there are more patients that are getting ECG done because of the and administration of it, and so more patients are getting ECGs. The take-home message is that electrical events come before mechanical events. Remember how to put the limb leads and the argumental leads, the differences. The ECG is easy to interpret. It might feel a bit, right? But generally, the first time I dealt with ECGs was, of course, like all of you, when I was a 4th year, and I took a liking to it. And I'll show you the places I went to when I was a 4th year, which there's this guy in YouTube is very easy to follow, several videos. And then after that, of course, practice. And when you become better at ECGs, all your classmates come to you, tell you to interpret for them. So with that, you get to practice more the ECGs. So even at our postgraduate level, there are people who still are ECG averse. And but ECG should be a thing that you guys have at your fingertips by the time you're exiting, because sometimes it's between life and death. The physician who is able to interpret the ECG can decide if this is ominous or not. Those are the differences you have. With that, I'd like to, if there are no questions, I'd like to call it a night and return the meeting to Abdallah.
Alhamdulillah, that brings us to the close of part 1 of the ECG series. Thank you, Dr. Adan AbdiJabar, for the truly insightful and engaging session. You have made this complex topics so much more approachable to us. To all our attendees, thank you for attending. We hope tonight's session has deepened your understanding of ECG interpretation and at least left you eager to learn more. And kindly do try to attempt the questions from the Twitter by accessing the links in the chat box to go to the Twitter poll of Pace Medicine to test yourself. And do make sure to follow, vote, and share. We look forward to welcoming you again for part 2 next week, inshallah, where we'll explore the CT and T-wave abnormalities. Do keep an eye out for the date announcement. On behalf of Sound KNH Academics Department, we wish you all a peaceful and productive evening. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. السلام عليكم.